Aloha, welcome everyone to the Hawaii Book and Music Festival. I'm Robert Perkinson, coordinator of UH's Better Tomorrow Speaker Series, and I am the moderator today. Today we're going to be talking about the epic events that we've all been living through, the greatest global pandemic in a century. We're deep into it now. We're in late October. Hawaii is just now exiting the worst wave of infection, the Delta wave this worst wave came quite late to Hawaii. We have some 80,000 confirmed cases, surely more, of COVID-19. We're closing in on 900 deaths. We hope not many more of those. Still, 900 deaths is no small number if we would have imagined what we expected early in this process, and that still puts Hawaii better off than any other state in per capita terms, amazingly. On the front lines of this, even before the fighting started, has been Jonathan Dworkin, our guest today. He's an infectious disease specialist affiliated with Queens. He's now on the Big Island. And although he's been treating patients at a frantic pace all through this pandemic, he emerged as an especially lucid and urgent voice in public health in media early in the pandemic and had really quite significant influence on policy. And somehow out of the whirlwind, he has also managed to write an insightful and important book that is being published just now. And we'll put the image of it on screen. It is titled The Plague Doctors: How Hawaii Battled the Pandemic. And it is the first and the best attempt to write Hawaii's history of COVID-19 while that history is still unfolding. And in the process, it has a lot to say about medicine, misinformation, healthcare policy, political courage, how festering inequalities and political dysfunctions put us all at risk and what we might be able to do about it. So welcome, Jonathan. Thank you so much for your work, and thank you for joining us today.
Thank you for having me, and thank you for your generous encomium, which is on the back cover of the book.
You're welcome. It's nice to see you again. I've now spent a fair bit of time with you over these last months, and I have only met you in 2 dimensions, I believe.
Yeah.
And here we meet again. This pandemic has gone on for so long. It is difficult in some ways for us to remember what it was like when we were first starting to get alarming news, and maybe our first steps were to try to stock up on some hand sanitizer at Long's. But you as an infectious disease specialist, you knew that this was coming for you. So when did you first hear about COVID-19?
Like everyone else, I first became aware of it through news media reports around New Year's, early January. And when you're an infectious disease doctor, you're constantly hearing of new infections emerging, and most of them remain local phenomena and don't, drop in the way that it did, obviously. So I can't say that my first reaction was alarm. It wasn't. My first reaction was, oh, here's another new thing, and I was interested in it. I was a medical student when SARS-1 emerged. I had just completed an infectious disease fellowship when MERS, which was the other big coronavirus, emerged. And I remember doing a grand rounds at Queens Punch Bowl on emerging infections in the wake of the MERS epidemic. I was not surprised to see a new coronavirus emerge, but the previous 2 did not become nearly as disruptive as this one did. So I was not alarmed initially. I became alarmed when it became obvious that it was leaking beyond the borders of China. And when we began to see the really heavy-handed response in Wuhan that the epidemic necessitated. And at that point, a lot of people will remember the sort of official talking points that were being echoed by a lot of public health authorities, both in China and in the West, were to try to reassure people. What was happening on the ground was no longer reassuring. And I think that's when my antenna kind of went up. And I began paying very close attention to cases as they went beyond China's borders. And I tried to keep myself honest by defining in advance what I would consider truly alarming. And the criteria I came up for myself would be, non-China cases are growing logarithmically over a fairly short period of time, a week or 2. And I actually began charting on my computer cases as they spread beyond China. I was looking at, data being reported by countries like Singapore and Japan and Thailand, places like that. And what you saw through January was sort of a smattering of cases, not a whole lot, but an inability of those countries to stamp it out completely. So there'd be a case here, a case there, there'd be a few days of quiet, and then there'd be a few more cases. And this was despite very effective public health systems in neighboring countries. Japan and Singapore are not slouches when it comes to public health. The fact that they couldn't beat it down and stamp it out was alarming to me. And then in late February, you saw a real explosion of cases in Korea, Italy, and Iran in very rapid sequence. And that's when it became obvious to me that we were dealing with a pandemic. I had my suspicions before then, but that's when all illusions were barred.
So was it clear from those first outbreaks that couldn't be contained? Was it, the two characteristics that set SARS, this particular virus, up apart from the other coronaviruses, MERS and SARS that you talked about, at least as I think I understand it, like lower fatality rate, but much greater infectiousness.
That's right. That's correct. And asymptomatic transmission, which is, I think, what really got us. And it wasn't entirely clear early on. I mean, at first, the Chinese government did not even acknowledge that human-to-human transmission was happening, but it was obvious that it was happening. And then the question was, okay, how contagious is it? And is there transmission that happens before people become symptomatic, or can people actually go the whole course of an infection asymptomatic and transmit? And the answer to those questions was yes. And that's what makes, symptom-based screening, which was sort of a mainstay of controlling epidemics, emerging epidemics, ineffective in this case. So you need to get much more aggressive with your infection control measures if you can't rely on symptoms in cases. And I think that's why a lot of the early border control stuff failed. You saw very aggressive contact tracing efforts in places like Singapore and Japan that kept numbers in check, but couldn't eliminate transmission chains altogether. And for me, that was kind of definitive. The China data was interesting because they obviously had a massive outbreak going on in Wuhan, and that was real, but it was a little hard to make sense of what their reporting was because there were some things they were very forthcoming about and some things they were not. And I thought it would be wiser to focus on the surrounding countries in order to get my own head straight in terms of what was going on.
And so in terms of what we thought we knew at the beginning, there was a lot of emphasis early on in terms of public health and the possibility of surface transmission. Temperature checks had been, I guess, a fairly effective tool at containing MERS and SARS.
Yeah, with MERS and SARS, people become very sick, including symptoms like fever, and then they transmit. The fatality rate in those infections was much, much higher. But more importantly, in terms of disease control, there wasn't really asymptomatic transmission. People were symptomatic and then they were transmitting. So once you could define a case, a patient under investigation, to use the CDC terminology, you could then effectively shut it down. That completely failed with this virus.
So back in February, say, I presume you were at Queen's Punch Bowl mainly at that point, or
That's
were you
right,
also
yeah.
practicing on the Big Island?
Yeah.
I presume by mid-February, you must have known you were going to get cases.
Right.
So did you have more false alarm cases before you had actual cases?
Yeah, and people who know me know that was in some ways the worst part of the pandemic for me. I knew it was coming. I was not at all reassured by the reassuring messaging we were getting from, federal and state public health authorities. I was in contact with physician colleagues who have done international work. So I was looking to see, what they were saying. That there were, we have a number of physicians at Queen's Punch Bowl who work in Japan. We were all talking about, is it going to come from Japan? We knew we had a lot of travel from Japan. What we did not know was that it was already transmitting in the continental United States, and we had just missed it, right? But we knew with all the travel connections in Hawaii that it was going to come. And that made all the travel that was happening in February very concerning, right? So we didn't have an ability to test for it. We were stuck with these travel-based test criteria. And at first they were extremely restrictive. It had to be a patient from, Wuhan essentially. And then they liberalized it a little bit, said, okay, anybody traveling from China. And then it was okay, anybody traveling from China, Korea, or a couple of other places. But every time they liberalized the travel criteria for testing, they were weeks behind where the epidemic actually was. So one of the interesting things, and I discussed it in the book at the beginning, was just how badly we were defining potential cases, and how we had this overly restrictive criteria that not only failed to catch cases, but actually falsely reassured everybody that there wasn't transmission happening when in fact there was transmission happening. So it fit in with the whole false reassurance narrative as well, because we were saying, well, we don't need to test people unless they've been to one of these places, even though the disease was already past those places. And then that made people feel safe when in fact the situation was not very safe.
And so we were only in those first days then catching cases, A, that were linked to travel, which was incorrectly, tragically restrictive, but also because the symptom profile was too narrow?
I think the symptom profile was appropriate, but the problem was there was already some evidence that there was pre-symptomatic or asymptomatic transmission. So it was becoming clear even at that point, because the Chinese published very quickly on the clinical spectrum of the disease, and the data that they were publishing on the clinical spectrum of the disease was excellent. And those were the first papers I remember reading, were all done by Chinese groups. And they were discussing pre-symptomatic transmission and asymptomatic transmission fairly early on. So we knew that, we should have known anyway that was a potential problem. And we didn't have the ability to test everybody. Obviously, at that point, we don't have the ability to do that now. But at the very least, I think what we should have been able to do was toss the travel criteria when they appeared to be irrelevant to people. And I was especially worried about healthcare, because we saw hospital systems getting crushed, and we saw transmission happening in hospitals, and we saw Chinese physicians and Chinese nurses falling ill, and then we saw Italian physicians and Italian nurses falling ill,
right? And
then we saw New York physicians and New York nurses falling ill.
Right.
We saw all of that coming at us, and we still had these silly criteria for testing. Made no sense. And my worry at that time was that we were going to become aware of it, through a healthcare cluster, and that would be disastrous, because then we've got the most vulnerable people in the state falling ill, and we've got the people who are supposed to take care of them falling ill, and that's not how you want to learn about the problem.
Yeah.
So those were my anxieties in February and March, and they were acute. I mean, things were tense as we were trying to ramp up testing, and I discuss it in some of the early chapters of the book. But I was sending emails that are not normally the kinds of messages I send to people, saying things like, "Don't let the law get in the way of standing up testing." It's better to ask for forgiveness than permission in a situation like this, and that didn't always go over well.
What about in terms of gearing up just for infection control and protecting healthcare workers with PPE and so on? Did that extra month that we had enable you to be pretty well prepared when you finally did get hit by cases?
Maybe this is an area of denial that I didn't appropriately conquer, but I feel like I had a lot of stuff in my house, I had a lot of tools, and the one thing that would have been super useful would have been a box of N95 masks. And by the time I realized it, they were already flying off the shelves. So we had an acute PPE shortage during that first wave that absolutely made things trickier. Because it coincided with the inability to test, right? So when you have an inability to test combined with a PPE shortage, the likelihood that you're going to have transmission in healthcare settings goes way, way up, right? And in some ways, our first big win was ameliorating those two situations. It just made the hospital immediately much safer.
Right.
Now we were lucky in the sense that we had excellent private labs, in particular diagnostic labs and clinical labs in Hawaii, that it did begin to stand up testing, and they did it just in time, because we almost certainly missed some early cases. But when the wave really hit, the tests were there, and they were. I'm trying to remember the exact chronology, but it was literally a week or two before we got hit with the real wave that we had the ability to test. And had it been the other way around, we would have had a major problem before we realized.
Maybe just like New York or Italy.
Yeah, exactly.
Okay, so what were the first when did you have your first confirmed cases, or what's an early patient who stands out?
I remember when we were still in the midst of that PPE and testing shortage, being pulled aside by colleagues and asked to look at X-rays. And, I remember looking at one X-ray in particular that looked just like a picture that had been published in the medical literature from one of those Chinese groups, describing the characteristic, peripheral ground glass opacities that you see on chest X-ray with COVID-19 pneumonia. And I asked, well, where's the patient? And the answer was, well, the patient was discharged from the emergency room without a test. So that was, maybe a week or two before the wave really hit. But there were a smattering of situations like that where I'm confident we had some transmission happening that we missed. The first confirmed one I had, I don't want to give individual patient details.
Of course.
It was a young person who was very sick and had risk factors related to travel, but not at all the traditional risk factors that had been the requirements for testing. Fortunately, by that time, the testing requirements had been relaxed a little bit, in part because some doctors in California pushed very hard to test the patient without a traditional travel history, and then got a positive result. And then that upended the whole thing. And we couldn't pretend anymore that it was purely China travel or Korea travel. So when it happened, it wasn't subtle. It was a wave of patients,
I see. And what treatment protocols were you able to follow very early? And what tools did you have in, say, April?
Not a lot. If you're going to get infected with a novel pathogen, it's better not to be the first people to get infected, because everybody's trying to figure out what to do. It's now October 2021, and we still don't have good antiviral treatments for COVID-19. Right. We're just about to get them. There's some oral antiviral stuff that we're finding now that's about to work. And we have monoclonal antibodies, which is an antiviral therapy. Mm-hmm. At that point, we really had nothing. There was an experimental drug, as you know, hydroxychloroquine, which, there were some observational data that came out of Korea and China that showed it might work, and it had worked its way into some of those guidelines. So some of us were interested in trying it. But as soon as the randomized controlled trials came back, we realized it didn't really work. So, at that time, if you got COVID, you were maybe going to get hydroxychloroquine, maybe get nothing. You were going to get supportive care, but even the supportive care wasn't as good as it is now, because we didn't really know the best way to support these people. We knew that they needed oxygen, but at that time we were intubating too many people, which we realized was wrong.
Yeah, that was a kind of interesting development in the clinical practice that, as time went on, it seemed like the criteria for putting someone on a ventilator became much stricter.
One of the first observations was that people who got ventilated did terribly. So once we realized that they were doing terribly, we were like, well, let's stop doing this. It's not working, and we started looking for other ways of supporting them through it. We also had a lot of blood clots early on, because this is a very, thrombosis inducing condition. And, we had through that experience, we realized that we should be much more aggressive at anticoagulating people when they come in with COVID-19 pneumonia. So now we're not seeing nearly as many blood clots. But, if
steroids were you using early on?
No,
or?
In fact, we thought it was bad, because that was the experience with some other infections. So we were avoiding steroids. So, this has been a disease that's changed very quickly to management. And every time there's been a wave, we're now on, for me, the fourth wave with Delta. Each wave, my practice has been different. And I can't think of another disease where I've updated the way I manage it so quickly. But month to month, things are very different. And we have gotten better at it. I still think we're pretty lousy at it once you get COVID, which is a good reason not to get COVID. But there's no doubt that the supportive care is better.
So how were you doing that medical research in real time, were there enough cases for you to see observationally that ventilation wasn't working well, or is that from emails or print data, or was how was that information being exchanged?
The preprints were big. People are sharing now very quickly. So, I remember going on to message boards when the wave hit California and looking at what infectious disease doctors in California were doing. That was a couple of weeks before we got hit. I remember reading very detailed threads of basically infectious disease doctors and pulmonary ICU doctors talking to each other on these little chat threads. I saw this, I saw that, I'm doing this now instead of that. So I read a lot of that stuff. None of that's peer reviewed. That was just
no, of course not. There's not time for that.
But it was helpful for me, and like I mentioned, some of the Chinese doctors published very quickly. So I had a sense of the clinical syndrome pretty early. Stuff was getting published very fast, and then things were being put up on preprint servers even faster. So, my average daily reading list at that time was, 5 or 6 full-length articles a day, on the clinical syndrome or on a related infection control public health kind of question. So we were also trying to figure out, well, what's the right isolation procedures and how long do we have to quarantine people if they've been exposed? And all of these things were coming up at the same time. So it was just constant reading.
How big was your infectious disease team that was kind of trying to devise whatever treatment protocols you could manage?
At Punchbowl, there's an excellent division. And they're all individuals though. There's 7 or 8 of us. And we were divided into a couple of big call groups to cover like weekends and holidays. So we play nicely together, but we're all individuals with our own little practices. And what this required us to do was to really synchronize our efforts. I remember having conversations with my colleagues where I said things like, I don't want to be rounding on a COVID patient and then go into the oncology unit and see a patient with neutropenic fever, especially when we didn't have appropriate PPE and we didn't have appropriate testing, right?
Right.
So at that time, it was very important to maintain a kind of cohorting where we would assign, individual infectious disease physicians. We actually created a call schedule for COVID. And I believe I was on the first couple of weeks. This is a long time ago already, but I believe I was on the first couple of weeks that we had the COVID call schedule. I was one of the people on. And that was during the initial wave in April 2020. And that's all I did those couple of weeks. And then I decompressed a little bit, and then I went back and I did non-COVID for a few weeks, and then I was back on again. So, we tried our best to work well with each other. But of course, we all had our non-COVID patients. And as time went on, those people were increasingly feeling the neglect of having the hospital system disrupted. And some of us also rounded in multiple places. I was going to North Hawaii and the Big Island. Some of my colleagues at Punchbowl were rounding at multiple other hospitals in Honolulu.
Which is potentially also a transmission risk.
That's right. So all of these things were on our mind, and we were concerned about it.
Sure. Just maybe as a little bit of background, because you mentioned your other cases, maybe tell us a little bit about how you decided to go into this specialty infectious disease was this in your residence you made this decision?
I'm a bit of a weirdo in this way. I wasn't even sure I wanted to be a doctor. When I was an undergraduate, I majored in literature actually, and some of my favorite classes at Brandeis were actually American Studies classes and humanities.
Oh, that's great. That's me, American Studies, as you know.
Yeah. So there was a wonderful program at that time that I think still exists called the Humanities in Medicine program. And Mount Sinai, which was the medical school I went to in New York, they reserved about 1/5 or 1/6 of their spots for kids who were humanities majors in college. And the conceit of the program was that we don't just want biochemists to become doctors. We want all different types of people to become doctors. And
wow, that's really interesting.
It was a wonderful opportunity for me because I was going down that science track, and then I was able to get into that program and spend the last couple of years of college kind of broadening myself. Once I was in medical school, I don't know why, but I found myself very drawn to infectious diseases right from the get-go. They tie into history. The history of pandemics is the history of civilizations. And, taking care of infectious diseases can be very rewarding as well. I feel like you're brought in often, there's a diagnostic question. Someone's not doing well, they're infected, or we think they're infected. We don't know exactly what it is. We have to figure it out. If we can figure it out, then we can offer a treatment, often one that cures them. And I like curing people. It feels good. I found that very satisfying. I liked that it was so geographical that you could travel with it and that you could go anywhere in the world as an infectious disease doctor. So these were all aspects of it that I found really compelling. So I knew pretty early on that was probably what I was going to do once I had committed myself to the medicine route. And I always thought Hawaii was a wonderful place to do it.
So what were the sort of pathogens that you were most dominated your practice before coronaviruses?
Yeah, well, one of the first things you notice, like, so when I moved to Hawaii, I did my residency training at Queens, at the University of Hawai'i, and most of that was at Queens Punch Bowl. So when you're walking down the hallway in Queens Punch Bowl, there's a portrait of Queen Emma up on the wall, and she kind of looks at you, and you know, it's a friendly look, but it's also a, hey, are you going to help us or not kind of look, and I always found myself very humbled by that portrait and by the history of that institution in particular. And I began reading about it a little bit more. And I realized that the whole Queens health system was built in response to the smallpox epidemic in the 1850s. And when you read the history of epidemic disease in these islands and what happened to the native population, it's a massive historical tragedy and injustice. And you know, that was, in my mind, the backdrop for everything that happened with COVID-19. I was walking into a hospital that was built by the Queen of Hawaii in response to a deadly epidemic. And I was living through a deadly epidemic. And I thought, boy, I got to step up. I got to do my job here. You know, it's on me. Are we going to be in a situation where history repeats itself? Or are we going to be in a situation where we can give this a better ending? There wasn't one particular pre-COVID infection that I was fascinated by. I like the variety of the work. You know, a lot of the more pedestrian stuff that was happening in Honolulu prior to the pandemic is exactly the kind of stuff that you find in any big city in America. So, you know, I had a lot of patients who were you know, suffering from various forms of urban poverty, coming in with infected wounds or pneumonias, things of that kind. And then I had patients who were elderly or frail or immunocompromised, who had cancers, who were getting treated and they were immunosuppressed from their cancer therapies. Those were the kinds of cases I had and continued to have all through the pandemic. That stuff didn't stop happening just because we had a pandemic.
Of course. How much did those patients, I mean, you mentioned that there was this kind of neglect, but how much how much consequence do you think that had in terms of quality of care for people who weren't infected with COVID during this period?
I think it mounted over time, you know. So you can do things like stop elective surgeries and close the chemotherapy infusion center for a week or two and get away with it. But when you have months of disruption, that starts
to affect outcomes.
It starts to affect outcomes. That's exactly right. Now, that said, there was an argument made at the beginning, which I think was disingenuous, that, you know, we should just focus on those outcomes and not try to control the virus at all. And that would have been completely wrong, because this was a virus that had the capacity to completely overwhelm the healthcare system. And the sort of let it rip approach, which was advocated for by some at the beginning, would have also disrupted care for everybody else. It would have just led to a larger mortality event from COVID. So we had to be able to kind of walk and chew gum at the same time. We had to be able to respond to the pandemic aggressively and control the spread, but also maintain some level of functioning for all of our other patients.
I think it's instructive that you mentioned the history of Queens in response to the smallpox epidemic, because of course, everyone in this COVID-19 outbreak has received these sort of thumbnail histories of pandemics in world history that kind of start with the Black Death and then feature the Great Influenza in World War I. But perhaps the greatest mass death involved indigenous peoples in the Americas, and then in the Pacific, as European colonizers arrived and brought pathogens with them, and the death toll, is in the tens of millions at least of people who died in wave after wave after wave of population suppressing pandemics all through the Hawaiian Islands and all through North and South America too. And that's what's so tragic, is that we have seen some repetition of history in that, lo and behold, the populations that have been hit hardest by COVID have been those, most historically, intergenerationally decimated by infectious disease, and those most economically disadvantaged. Did you see health disparities affecting COVID outcomes and shaping it from the very beginning, or did it take some time for that to become clear?
Pretty quickly. The first wave of cases we had in Hawaii was mostly travel related. So that population was a mixed population of people who were traveling. I saw a lot of cases that were related to Vegas at the very beginning. I still see cases that are related to Vegas, by the way. So that's
a whole epidemiology paper right there.
That's right. There's a whole epidemiology paper there. But especially that second wave in the summer was one that was skewed very heavily towards a Pacific Island population, and what we saw was it got into crowded intergenerational housing, and it just ripped through, right? And this is not unique to Hawaii. We saw it rip through crowded intergenerational housing all over the world. So we knew that was coming. And one of my frustrations, which I describe in the book, is knowing that was likely to happen. My colleague David DeRoff brought it up in the very first meeting we had together with the state task force and COVID response. So, we were aware of this, and then it happened, and we seemed to be helpless to stop it from happening.
I interviewed you about this in April, I believe.
Yeah, that's right. We were beside ourselves over this, and I'm not enough of a sociologist to understand all of it, but it seemed to have a talent for preying on the vulnerable. And particularly, the virus doesn't care. The virus is just going to get where it can get. But, people who are socioeconomically disadvantaged are more likely to be in crowded intergenerational housing. And they're less likely to be able to work.
Yeah, right. Or less likely to be able to work on Zoom.
That's right. And we saw something similar in New York, where it really impacted immigrant communities in Queens, in New York. The hospital that I did my infectious disease rotation in as a fourth-year medical student was Elmhurst Hospital. And that's a very diverse urban hospital in Queens, New York. I think it's one of the most diverse square miles in America.
And one of the hospitals that kind of famously got hit really hard, right? By that,
they got crushed.
Initial wave. Yeah.
They got crushed by the initial wave. Yeah. So we had our own little version of that in some of the more urban parts of Honolulu, and Queens bore the brunt of it.
So when it came to kind of seeking to, or kind of maybe being compelled to weigh in on policy questions in addition to patient care questions, I presume that started happening first at the hospital level or at the health systems level. So were you, how did Queens do, in your estimation, compared to other major healthcare providers in kind of preparing and setting in place protocols in the winter in preparation for the first wave, and how much were you involved in kind of setting those policies without getting you in trouble?
I was a big nudnik at that time, I remember. But I think, like any other collection of humans, we had a variety of opinions on A, how serious it would be, on B, what the appropriate response should be, and also on the pace of the response. Once I decided in my mind, sometime in mid-February, that this was coming at us fast and it was coming at us hard, I kind of lost my filter internally and began really pushing very aggressively for us to stand up systems, in particular testing and things like that. Even if the people that had to stand those systems up didn't feel ready to administratively. That said, I think we got on the same page very quickly, and I have to credit the Queen's leadership for seeing the big picture there. They set in motion processes that allowed everyone's voices to be heard and the best ideas to emerge. And pretty quickly, certainly by I'd say the first wave or the middle of the first wave, we were kind of firing on all cylinders. We had testing up and running. We had a system in place for PPE use and PPE recycling. We were beginning to standardize our approach to supportive care and to treatment. We were beginning to standardize our approach to clinical trials. We were beginning to standardize our approach to infection control. Not everybody agreed with everything, but I think, and not only that, when we began arguing a little bit with the state on things like discharge, I didn't feel comfortable during that first wave with some of the discharging, because people were going back into those crowded intergenerational houses. Well, Queen's administration stepped up there too and began trying to find hotel rooms for people. So
yeah, okay. Well, this gets us into talking about the policy in the state and the
Yeah.
city more generally, because as we have learned in a pandemic, as important as healthcare providers and hospitals are, they may not be the most important tools to contain a public health crisis of this magnitude. And you also really need testing and isolation and contact tracing. There were a lot of factors nationally that led to a sluggish start in testing. But our sluggishness in hiring personnel to handle contact tracing maybe falls more on us. As you know, I was quite dismayed that we didn't do a better job of isolating people, even though we had an island full of empty hotels.
Yeah.
That gave us a lot more capacity to isolate than, besides Vegas, almost any other city in the country. Like, we really had the capacity to do a lot of isolating to try to contain the pandemic. When did you first start getting pulled away from patient beds and into political offices, at least maybe virtually, though that was?
I had colleagues who were working with HBMF, and I described this in the book, who asked me to comment.
This is Hawaii's emergency management agency out of the,
correct,
from state government, just to make clear.
Yeah, the Hawaii, right, exactly, the Hawaii branch of FEMA. And I was asked to actually weigh in on some of the discussions. And when I began to look into disease transmission and the impact it would have on healthcare, it became obvious very quickly that if we didn't do something to interrupt transmission, we could do as well as we wanted to do in the hospital, but we were going to get overwhelmed. And we certainly weren't going to do as well in the hospital in April of 2020 as we were going to be able to do in October of 2021. We all knew that. We all knew we would only get better with time. So could we interrupt transmission enough to buy ourselves some time to be better at this? And that was sort of the rubric that began to form in my mind around that time. And there were a couple of specific experiences related to that. There were academic centers on the mainland that were doing modeling of the epidemic, and you could go online and you could play with some of these calculators, which I did, and you could change, for example, the lethality of the disease. You could make the disease more or less deadly, or you could change things like transmission dynamics. And what I noticed when I did that was, if you change transmission dynamics, you had a much bigger effect on the mortality event than if you change the lethality of the disease, interestingly. And it's because of the nature of exponential growth. These epidemics are mathematical phenomena, and they grow exponentially. So when you interrupt transmission, you're interrupting exponential growth. And once I realized that, I began looking around at our system, and I thought, well, we can do as well as we want in the hospital. I can improve mortality 10% or 20% by doing A, B, and C in the hospital. That's not going to mean anything if we have out of control transmission in the city. So what are we doing to control transmission in the city? And because I had been invited to comment on this for HBMF, I began looking around at HBMF and saying, what are you doing? What are you doing? What are you doing? And that became increasingly frustrating very quickly, because what I encountered was essentially a mirror image of the mindset that had played out on the mainland, which was, this is a respiratory virus. We really can't do anything about it. It's going to run its course. We don't want to kill the economy. Let's just prepare to surf the wave as best we can. We'll bring in some extra ventilators, that kind of thing. And it was, I thought, very wrong-headed. So I began focusing like a laser beam on transmission interruption strategies. And in doing so, I bumped into and befriended some of the epidemiology folks. And I was relieved. One of my first conversations with Tim Brown was around this set of questions. And he had a much more sophisticated understanding of the epidemic modeling than I did. But I was relieved to find that my conclusions from that were pretty closely in alignment with his, and that we needed to do what we could to interrupt transmission. So those guys became my kind of crew, and along with a few other clinical docs who saw it the same way. And we began focusing on transmission interruption as part of the disease response, even though that was not strictly part of my job as a clinical ID person.
Well, so when did you first realize that assembling the data and making fact-based, reasoned case in a formal meeting was not going to be enough.
Well, I've been around long enough to know.
If only the world worked that way.
Yeah, to know that a lot of things don't get solved in meetings. And what I was looking for was people who would take responsibility for one component or another. And what I found was some people were willing to and some people weren't, right? Some people at those meetings were interested in thinking outside the box in order to do whatever we needed to do to interrupt transmission. And some people were interested in explaining why the system doesn't work that way, right? And I found myself drawn to the former and kind of repelled by the latter. That's sort of the way my situation evolved. I didn't last very long in HBMF, and there was one point, where I was nudging for. I think I was nudging for quarantine hotels and some sort of system of centralized quarantine, and then a couple of days went by, and I realized I was no longer being invited to the meetings, right? And if things had stopped right then and there, it would have been a dismal failure. And I realized I had just talked my way out of having any influence on anything, right? Fortunately, there were other people who were hearing that message from me and from some of my colleagues and agreed and re-invited me into other aspects of it. So one thing that happened, for example, through the process of discharge planning from Queens Punch Bowl was I wanted to get hotel rooms for some of these patients that I thought might still be contagious at the time of discharge and that were in kind of unsafe living environments. So we started working on that through the hospital angle, and then we started working on that through the city and county angle. And the next thing I knew, I was getting roped into city and county meetings, and that was a crowd that was a lot more receptive to outside the box thinking in terms of how to interrupt transmission. So, not to say that they agreed with everything I said, but they were at least interested in hearing it. And David and I ended up migrating over to them.
To the city's kind of emergency response group.
That's correct, and that was under Kirk Caldwell.
Mm-hmm. And what kind of changes, do you feel like you were able to affect?
Well, I think one of the things that
maybe quite a lot. Like the city did become increasingly assertive as an entity as the pandemic went on. They detailed a lot of smart city employees to work on the pandemic. They started gearing up their own bureaucracy, even though it wasn't their purview really at all, at least in the way the agencies were arranged. So
I think
I presume some of that came out of your advocacy.
Yeah, there were a couple of impacts that I think we had directly or indirectly. One which we just sort of forced the conversation to change, and that might have been the most impactful thing we did, because instead of it being, the risk is low, the situation is under control, and all the sort of official state talking points just being regurgitated ad nauseum, suddenly we had city and county people saying, no, actually, we think you need to be doing this, or we think you need to be doing that. We have our own medical advisory committee that's very hard to have hotel quarantine set up. So they didn't, the state was not happy with that at all at that time. But because we had a foundation there within the government that we could use to sort of push the issue, we were able to push the issue. Eventually, the city did end up doing a lot. They ended up doing a lot of their own testing or financing testing in various ways. They ended up paying for a lot of isolation hotel rooms. They ended up, paying for a lot of contact tracers. And the best event ended up occurring, which was that the city and the state plans merged together after August, September of 2020 with the change in DOH leadership. And then there was no longer as stark a divide between city and state in terms of the disease control effort. That took several months to happen. And before that happened, it was an adversarial relationship. It really was.
Yeah. So in your estimation, Hawaii has done by the numbers better than any other U.S. state, but that's a really low bar. I mean, for a country as wealthy and as equipped as the U.S. ought to be, what do you think we did worst? And of course, then I'll be optimistic and ask what you think maybe we did best.
Towards the end of the book, after talking through all of my experiences clinically and then talking about this whirlwind of policy that I got sucked up into, I kind of come back to this question. And there's a couple of charts in the book that get at this, where compare Honolulu to other big urban centers in the United States in terms of the mortality. And I used the cutoff of when the vaccine rollout began, because after the vaccines became widely available, differential outcomes had a lot more to do with vaccination than anything else. But I was interested in this idea of, well, how well did we do with the actual disease control? How well did we do with interrupting transmission? And that includes things like border control and contact tracing and testing and isolation and all of those types of things, quarantine. Honolulu, compared to other urban centers in the United States, looked very good at that point. But if you compare Honolulu to small island nations in the Pacific, who right. I think are maybe more appropriately our peer group, we don't look as good. We look very mediocre, you know. And I think the reason why
terrible in some instances.
Yeah, that's right. So I think this
there are
narrative
places,
of sort of we're the best in the United States and we should all pat ourselves on the back. It's a bit false, because some of our immediate neighbors here in the Pacific did way better than we did. And you know, they had more rigorous public health responses from the very beginning. You know, they didn't have to fight to get contact tracing done in Hong Kong or Taiwan. They just did it right from the very beginning, right? Or Singapore. They didn't have to fight to have effective quarantine for infectious people. They just knew to do that right from the very beginning, right? They didn't have to fight over border control. They all did very aggressive border control from the very beginning. For us, those were big, you know, knockdown political battles that were extremely contentious. And the result is that, you know, our performance relative to those other countries is fairly poor. We did end up doing most of those things, at least partly. And I think, you know, it wouldn't be fair to say that we did terribly, because we are part of the United States, right? Mm-hmm. And we're particularly dependent on the rest of the United States, more so perhaps than some of those other places are. But yeah, I think I get into that in the book, and I think it's a mixed result for sure.
I mean, I have wondered whether we did comparatively better than other U.S. states simply by being an island, in that we did interrupt travel, maybe not completely, because there were all of these carve-outs for federal employees, including military employees and their families. So a lot of travel was still going, even when tourism was shut down.
That's right.
But travel in the rest of the U.S. wasn't ever shut down at all.
So we had about 7 or 8 months where we had a mandatory 14-day quarantine for all trans-Pacific travelers. And if you had told me in February that we were going to do that, I wouldn't have believed you. That was a big deal.
That's a big deal.
As was the early lockdown in the city and county of Honolulu. Now, maybe it went on for too long. Maybe we could have opened up sooner. Maybe when we reopened, we did it in a way that was screwy. But that initial first couple of weeks of lockdown undoubtedly saved lives. And the 14-day quarantine undoubtedly saved lives. And had we not done those two things, I think we would have been looking at a much bigger mortality event in early to mid 2020, which was when we were least equipped to deal with it. So, you know, many of our failures came later, when we were at least somewhat better equipped to handle them. And I think that's an important point.
Sure. Do you think if the Department of Health had rallied to this as an emergency rather than as a bureaucracy, you know, that we could have saved many more lives also? I mean, I guess that primarily would have been through real contact tracing, it would have hiring at a faster rate.
Yeah, it would have required a completely different framework. And the Department of Health has reformed itself to some extent, but I still think that they're not reformed to the point where they would be really effective in a situation like this. You probably recall in May of 2020, early June, we had very few cases in the island. We had a mandatory 14-day quarantine for all trans-Pacific travel. So what we had was endemic transmission that was at a very low level. Now, if we had really
20 cases a day, maybe lower some days.
At one point, it was single digits or lower. Yeah, right. And then we even had days where there were no cases. You know, so what if we had really stepped on the virus at that moment? And this is one of my regrets. I was urging for it in my discussions with the city and county of Honolulu, but it was hard to mobilize the resources to do it. What if at that point, you know, we had dramatically driven up our asymptomatic screening and our contact tracing? You know, we could have potentially eradicated transmission.
And there was the federal money to do it, which was what was by that point, we were flush with federal dollars that we were not able to spend as rapidly as we needed to. So
Right.
We could have been doing all that for free.
And we could have been developing more long-term infrastructure at that time so that when we reopened the border, we would have things available like post-arrival testing, which we still don't have available, right?
Right.
So there were things that we could have done at that point if we had had imagination, that I think it's not too late to do them now because this epidemic isn't gone. We're going to be living with it for some time. But ideally, we would have done them right from the get-go, like the Koreans did, right from the get-go. And it would have made our entire reopening process a lot safer.
Some of the blame lies with political leaders and leaders of that agency, I think, but some of it, I also think, lies in American political culture, that we've been living through 40 years of budget cutting, and the agencies that have been most assailed by conservatives have been those kind of soft power agencies. We've put a lot of money into the military and police and prisons, and these other social service agencies have been kind of starved. And so then when it was their moment, these weren't agencies used to assuming command of a crisis and demanding resources. It was interesting here in Honolulu to see how the police department was an agency that was used to taking control, voicing itself, and spending money. Like, they started spending federal money like crazy, buying all sorts of things probably we didn't need, like robots. But they were used to, they had confidence, I thought, as an agency, whereas the Department of Public Health, like, they just could not hire 20 people, it seemed like sometimes, right. Which was amazing. We have a country full of firefighters who we don't assume that they have to be fighting fires all the time to justify collecting a paycheck.
Yeah.
You could have contact tracers sitting around using federal money, waiting for a case surge, but we really didn't do that.
There's leadership is important, and imagination is important. And when you're dealing with a crisis, you have to be able to think ahead a couple of steps, and you have to be willing to take risks, and you have to be willing to move quickly, and you have to be willing to be wrong from time to time for the sake of moving quickly. And none of those were qualities that we had encouraged at all in any of our state bureaucracies. Once I was aware of that, some of my colleagues were aware of that, we started pushing for more private-public partnerships and saying, okay, maybe the state is not best equipped to do this, but the least you can do is not block other people from doing it,
right.
and start working with people outside the system to build some of these capacities. So I think it's not too late to do that, and my hope as we go forward is that we begin to do that much more aggressively. We're now beginning to see, for example, widespread use of asymptomatic testing and rapid antigen testing, right? It should have been a year ago, frankly. But it is finally happening. So is that going to be something that we institutionalize and that becomes reflexive for us with the next pandemic or with another phase of this pandemic?
We're starting to close in on the end of the hour. So I want to make sure that we return to kind of clinical practice in the present. There were a lot of basic predictions about the virus, the case fatality rate and the scale of deaths and infections that thoughtful observers and modelers were making early on proved to be tragically accurate. One thing I did not expect was that Hawaii would get hit with its most severe wave of infection and death many months after incredibly effective vaccines were made available and after the state had done pretty well compared to some other places in getting its population vaccinated. Your book was finished, maybe most of it before the Delta wave struck. Is that right? That's right.
And I had to go back and write an afterword to get us up to date through August and September, which was not a joy.
So how did it or didn't it kind of upend some of your thinking about the COVID-19 pandemic as a whole?
Well, before Delta hit, we had vaccinated close to 60% of the state. And the truth is that was enough to crutch the previous waves of COVID that had come through. So the number of people you need to vaccinate and has to do with how contagious the virus is. But the enemy has a vote, and the virus mutated. And this strain is far more contagious. This is one of the most contagious viruses in the world. It's more contagious than smallpox. So 60% is not going to cut it. And what we saw was an increase in all infections, including in breakthrough infections in people who were vaccinated. But mostly what we saw was unvaccinated. The vast majority of cases were unvaccinated, and the vast majority of hospitalizations were unvaccinated. So, the Delta wave
imagine
in
imagine
August
if
and
this
September.
Delta wave had hit with 0% vaccination.
Well, and we don't have to imagine, because that's what happened in India, and they experienced, we estimate several million deaths. It was a complete disaster. So, at least we didn't have that. But it was still a wave that was deadlier than any of our previous waves. And rounding in the hospital was a surreal experience at this time. I mean, for me, it was the most demoralizing wave of any of the waves, because it was all, or 90% of it was preventable, right? And I'm rounding on people who had months to do the right thing and didn't do the right thing, and then got extremely sick. And many of them realized that. Many of them realized that they hadn't thought it through the right way. And some of them even offered to help us vaccinate their communities if they were leaving the hospital. That's
something.
Yeah. So it was not all gloom and doom, but there was an element of resentment and paranoia as well, where the denial was just so thick. And we had people, demanding irrational treatments and, recording us and calling their lawyers and stuff like that. People were behaving very crazy. And, some of this, I think, is just the result of having been through the pandemic for 18 months now. I mean, we're all sick of this. But this was a remarkable own goal, is the best way I can describe it. I mean, this was a big human disaster, and it had a major impact on vaccinated patients who were not COVID patients, because we couldn't really do anything for a month other than deal with its wave. At the peak in our rural hospital, I'm now on the Big Island. At our peak, we had half of our beds filled with, I remember the peak day, I looked at the census, half of our beds were COVID, and our entire ICU was COVID. And all of those people, every single one of them was unvaccinated. And it just blew my mind that my community here would inflict that level of suffering on each other for no good reason. And my sympathy for it really ran out very quickly. I'm now at the point where I think we just need to do whatever we need to do, get this community as vaccinated as possible. Measles, if the vaccine rate falls much below 90%, and I think that's kind of where we're at here too.
How much more infectious is measles than Delta?
It's a little bit more infectious. Yeah, it's the next level up. I think ours is about 12 or something.
Yeah, I mean, that was another thing that we didn't anticipate, is that coronaviruses are supposed to mutate kind of slowly.
Yeah.
But when hundreds of millions of people have it, that's an awful lot of opportunities for mutation.
Yeah, and how this plays out over time is still a bit of a mystery. And there's a debate over this. I was just listening to UCSF Grand Rounds the other day, and they had on a person who's an evolutionary specialist in virology. And the big question from the UCSF docs was, okay, where's this thing going? And the short answer is we don't know. And people are trying to figure this out. You can put these mutations into a computer and try to predict what kind of epitopes are likely to emerge going forward. But there may be things that we don't expect. There may be recombination events with other viruses, or there may not be. It may run out of runway, and the vaccines will hold. We're just not sure yet. And every day that goes by that we have a large unvaccinated population is a day in which the chance of something really bad emerging is allowed to happen. So this gets back at your equity question and getting vaccines to the rest of the world.
We're still not out of the woods with this pandemic, and this pandemic has made clear how vulnerable we are to other public health threats, perhaps public health threats unknown. What do you if policymakers have one lesson to take home from your book as they think about equipping us to meet future challenges, what is that lesson? What should they take home as we start, we hope, to emerge from this and look forward to fortifying ourselves better for next time?
Well, we need to be flexible, and we need to use the ocean, especially here in Hawaii. So we need to have policies in place that, in the event that something truly dangerous emerges, as bad as COVID or worse, and it could be worse, that we make immediate use of our border, and that we are resilient enough economically and culturally that we can survive a period like that. And that when we reopen, we have the tools to allow our adults to stay reopened. So this gets back at this idea of rapid antigen tests, and I'm particularly interested in locally developed rapid antigen tests. That's something that may have allowed us to open the border more quickly. So going forward, I think we need to internalize these lessons and not have a big fight about it when it happens, but just go into the mode of making effective decisions.
Thank you very much, Jonathan. Thanks for your exhaustive, tireless work during these many months of fighting this pathogen, and for all of your insight at the same time, which is remarkable to be able to do both. I hope it's thanks to your, as a humanities professor, I hope it's thanks to your training in the humanities and in the sciences that prepared you to cope with this so well.
Thank you. I'm happy to give credit to my humanities mentors.
our festival executive director is joining us to send us off into the night, I believe. And so thank you also to everyone who joined us tonight. I'm sorry that we couldn't get to many of your questions, but please contact us, and this won't be the only conversation we have. And please pick up a copy of Jonathan's book. It's an excellent and riveting and important read.
Thank you very much, Robert. Really excellent moderating. And thank you, Jonathan, for absolutely fascinating discussion. This is going to be up on the Better Tomorrow speaker series YouTube channel. If not immediately, it will be by tomorrow. And then later, the highlights of it will be edited into a highlight video, which will be up on our website for at least a year. So I'll alert you when that's available. And again, thank you so much. It was just a wonderful discussion. Aloha.
Nice to see you, Roger. Nice to see you, Jonathan. Thanks to everyone for joining us.